Okay, let's unpack this. Something like 12.5% of men and maybe 6.9% of women over 70 in the U.S. have asymptomatic carotid artery disease.
Yeah, just think about that for a second. That's a pretty significant number of older folks just, walking around with it.
And that really brings us to the heart of our deep dive today. Carotid artery disease. It's a major cause of ischemic stroke.
Absolutely. It accounts for somewhere between, 8 and maybe even up to 37% of all strokes. It's a big player.
What always struck me is that for a long time, the main thing everyone focused on was just how blocked the arteries were, right? The percentage of stenosis.
Exactly. You had those major trials, NASET, HECS, ECST,
Mm.
people might have heard of them. They basically established that surgery was, superior to just medication once the narrowing reached certain levels.
Right. Those trials sort of set the standard of care for decades. But here's where it gets really interesting, I think. Even with those guidelines, doctors started noticing something odd. You'd have people with similar levels of blockage,
Yeah.
but their risk of actually having a stroke was completely different. It didn't quite add up.
Yeah, it was a puzzle. Like the plumbing looked the same on the surface, but the outcome wasn't predictable just from that.
So it begs the question, right? If the blockage percentage isn't the whole story, what else is going on?
And that's led to this focus on the type of plaque, the stuff inside the artery. Turns out that's absolutely critical. We're talking about unstable or vulnerable plaques.
So not just a clogged pipe, but the kind of clog. That's the key difference.
Precisely. And these unstable plaques, they can cause trouble even if the narrowing isn't severe. Mild or moderate stenosis, you can still have problems.
Like those tiny silent strokes you sometimes hear about. Microinfarcts.
Exactly. Those can happen. So if you connect this to the bigger picture, just measuring how much the artery is squeezed, well, it might be missing a huge piece of the risk puzzle.
Okay. So that's our mission for this deep dive then, to really understand what makes a plaque unstable, what turns it from just being there to being a potential stroke trigger.
That's the goal. We want to explore the factors that define an unstable plaque, beyond just the simple percentage of blockage.
And just so everyone knows where we're getting our info, it's coming from a pretty authoritative source, Rutherford's Vascular Surgery and Endovascular Therapy, a major textbook in the field.
Good, solid source material.
Okay, let's dive in. What's the fundamental difference then? Stable versus unstable plaques. Where do we start?
Well, you could look at plaque stability through a few different lenses, really. There's the surface characteristics, what it's made of inside the content and morphology, whether it moves around, and even the blood flow dynamics around it.
Okay, lots of angles. Let's start with the surface. What does that tell us?
Surface features,
Mm-hmm.
like is it smooth or rough?
Yeah.
Well, plaque ulceration is a big one. Think of it like a pothole or a crack on the plaque surface.
Okay.
That's a key sign of a vulnerable plaque. Studies consistently link ulceration to microembolic activity, tiny bits breaking off and traveling downstream.
Little fragments heading towards the brain.
Yeah.
Not good.
Not good at all. And often these rough, ulcerated areas have tiny blood clots, thrombi, forming on top.
Yeah.
And you see increased platelet activity there too. Those cells involved in clotting get activated.
Okay, so a rough, broken surface is a definite warning sign. What about the inside? The plaque content? I sort of picture it as just hard cholesterol buildup.
That's a common image,
Yeah.
but it's more complex than that. Plaques have both softer, fatty components and harder, more sort of sclerotic structural parts.
Right.
And the current thinking is that the harder parts, the calcified bits, might actually help stabilize the plaque, make it less likely to break apart.
Oh, interesting. So calcium isn't always bad in this context. More calcium could mean more stable.
That seems to be the idea, yes.
Yeah,
You have
I know.
structure. The danger often lies more in the soft inner part of the plaque, what we call the lipid-rich necrotic core, or LRNC.
Lipid-rich necrotic core. Okay, break that down.
The lipid-rich means high-fat content. Necrotic means it contains dead cells and tissue debris. It's this soft, mushy, inflammatory center.
Mushy doesn't sound very stable.
Exactly. It's weaker, more prone to rupture, and more likely to trigger clot formation. You often see lots of immune cells active in there. And this can lead to something called intraplaque hemorrhage, or IPH.
Bleeding inside the plaque itself?
Yeah. Tiny blood vessels within the plaque can leak or rupture, causing bleeding right into that core.
Wow. How does that make it unstable?
Well, when you get bleeding inside, it often enlarges that soft necrotic core. It can also physically expand the plaque, potentially narrowing the artery lumen further. It basically makes the plaque bigger and mushier.
I see. And can we actually see this stuff?
We can. On ultrasound, these lipid-rich necrotic areas often appear darker, or echolucent because they don't reflect sound waves as well as denser tissue. And MRI is actually quite good at detecting intraplaque hemorrhage.
Okay.
And importantly, studies show that both the overall size of the plaque and the size of this necrotic core are linked to an increased risk of rupture. So bigger plaque, bigger soft center, higher risk.
Got it. Soft, fatty, bleeding inside. Definitely unstable characteristics. You also mentioned plaque mobility. Can these things actually move?
It sounds a bit strange, but yes, some ultrasound studies have identified what they term mobile plaques. These seem to have some independent movement within the artery.
Like they're not fully anchored.
Kind of. And this mobility has been linked to an increased risk of microembolization, those tiny particles breaking off, and consequently, ischemic symptoms.
Huh. That's surprising. Okay, the last angle you mentioned was hemodynamics, blood flow, right?
Right. How the blood flows around the plaque and the forces it exerts. The carotid bifurcation where the main carotid artery splits is a key area.
Because the flow gets turbulent there, like water hitting a fork in a river.
Exactly like that. The flow becomes less smooth, more disturbed, and this non-uniform flow, the shear stress on the artery wall, plays a complex role.
How so?
Well, initially, areas of low shear stress where the blood flow is slower or maybe even reverses slightly seem to be where plaques prefer to start forming.
Okay, so slow flow helps them get started.
But paradoxically, later on, changes in stress distribution, particularly areas of elevated shear stress, can be associated with plaque instability and rupture.
Wait, so high stress can make it break?
Yes, especially on the upstream shoulder of the plaque, the part facing the oncoming blood flow, or areas where the protective fibrous cap overlying the plaque is thin. High stress can literally tear the cap.
Ah, okay. So low stress to start, high stress to rupture. That's complex.
It is. And things like plaque asymmetry, if it grows more on one side, can create areas of concentrated stress. These differences in shear stress can damage the endothelial cells lining the artery and contribute to the thinning and disruption of that fibrous cap.
Makes sense. The cap is like the protective layer, and if it gets thin or tears...
The unstable core material can spill out into the bloodstream, triggering a clot. Big trouble.
And you also mentioned neurovascularization, new blood vessels.
Right. As plaques get bigger, the core can become starved of oxygen, hypoxic. The body tries to respond by growing tiny new blood vessels into the plaque angiogenesis.
Seems like a good idea trying to supply oxygen.
You'd think so. But these new vessels are often fragile, leaky. They're a major source of that intraplaque hemorrhage we talked about. So lots of neovascularization, especially in lipid-rich plaques, is actually another hallmark of instability.
Wow, so the body's attempt to fix it actually makes it worse.
In this case, often yes. It contributes to the inflammation and bleeding within the plaque.
This really drives home that stenosis paradox you mentioned earlier, doesn't it?
Absolutely. Studies like ACS and ACST showed that the degree of narrowing doesn't always correlate perfectly with symptoms. You can have high-grade stenosis that's stable and moderate stenosis that's unstable and causes a stroke.
Although higher stenosis often means a bigger plaque overall, right?
Yeah.
Which you said is a risk factor itself.
Correct. Higher-grade stenosis generally implies a larger plaque burden, and plaque size is associated with risk. But it underscores why just looking at the percent blockage isn't enough. We have to consider these features of vulnerability.
Okay, that's a great overview of the different angles. Now let's go a bit deeper into the structure. You mentioned histomorphology, looking under the microscope.
Exactly. Histomorphology is looking at the actual tissue structure. All atherosclerotic lesions, these plaques, basically start as something called a fatty streak.
Fatty streak. Sounds minor.
It is initially just an accumulation of lipids, like cholesterol and some inflammatory cells in the artery's inner lining. You can see these even in young people. They don't usually cause problems themselves, but can progress.
And there's a system for classifying how they progress, the AHA system.
Yes. The American Heart Association classification is commonly used. It goes from type I to type 6. Types I to 3 are basically those early stages, fatty streaks, some smooth muscle cell accumulation, a bit more lipid pooling, considered clinically silent.
Okay, early stages. When does it get risky?
The concern starts around type 4. That's when you get a distinct lipid core, forming the true atheroma. Type V adds fibrosis, more scarring around that core.
Still potentially stable, though.
Potentially, yes. But type 6 is what we call the complicated lesion. This is where you see surface disruption like ulceration or internal hematoma or hemorrhage or thrombosis, a clot forming on it.
Ah, so type 6 is basically the definition of an unstable plaque on a microscopic level.
Pretty much. Types 4V, and especially VI, are the ones considered to have embolic potential, the risk of bits breaking off. And indeed, one large study looked at plaques removed during surgery from symptomatic patients
Yeah,
and found features consistent with AHA-grade disc in the vast majority of them.
that makes sense. What else do we see under the microscope in unstable plaques?
Studies generally find that unstable or symptomatic plaques tend to have thinner fibrous caps covering that necrotic core. The cap is weaker, and they often have larger lipid cores, makes them more prone to rupture.
Thinner cap, bigger core.
Got it. Though it's worth noting, there's sometimes inconsistency in studies about whether overall plaque size or the presence of IPH specifically differs significantly between symptomatic and asymptomatic individuals with similar stenosis. It's complex.
Always nuances. You mentioned summarizing the differences between stable and unstable plaques. Could you walk us through the key points?
Sure. So think about the core. Stable plaques tend to have a more fibrous, dense core. Unstable ones have that soft, lipid-rich necrotic core we talked about.
Okay. Core, fibrous versus soft necrotic.
Then the cap. Thick and intact in stable plaques, but thin, maybe ruptured, in unstable ones.
Keep thick versus thin broken.
Intraplaque characteristics. Stable plaques might have more calcification. Unstable ones are more likely to show intraplaque hemorrhage, necrosis, ulceration.
Inside, calcium versus bleeding necrosis.
Cells. Stable plaques have more smooth muscle cells, kind of holding things together. Unstable plaques are packed with inflammatory cells, macrophages, T
The
cells.
cells, muscle versus inflammatory.
Biomarkers in the plaque tissue itself. Stable ones might show markers of collagen synthesis. Unstable ones show markers of inflammation and matrix degradation breakdown.
Markers, building versus breaking down.
Composition. Stable plaques are generally more collagen-rich, maybe calcified. Unstable ones are lipid-rich, cholesterol-rich.
Composition, collagen calcium versus lipid.
And finally, ultrasound appearance. Stable plaques tend to be echogenic bright. Unstable ones are often echolucent dark or hypoechoic.
Ultrasound, bright versus dark. That's a really helpful summary. It paints a clear picture of the two extremes.
Yeah, it helps conceptualize the key differences we look for.
Let's circle back to biomechanics for a second. That carotid bifurcation, the fork in the road being a high-stress area, why is that spot so prone to plaque buildup in the first place?
It's all about that disturbed flow. The geometry change creates areas where the blood flow isn't smooth or unidirectional. You get swirling, eddies, maybe even brief flow reversal.
Right, the turbulence.
And the hypothesis is that this non-laminar flow increases the residence time of particles in the blood, like LDL cholesterol and inflammatory cells near the artery wall. They hang around longer.
Giving them more time to seep into the artery wall, like a traffic jam allowing things to infiltrate.
That's a great analogy. It allows for prolonged absorption of these substances involved in plaque progression. Plus, the abnormal shear stress itself can trigger inflammatory responses in the endothelial cells lining the artery. It can even cause them to undergo apoptosis, or programmed cell death.
So the flow itself damages the lining and lets the bad stuff in.
It contributes significantly. Initially, the artery might try to compensate for this by expanding outwards positive remodeling to maintain the lumen size despite the plaque growing. But eventually, the plaque growth overcomes this, and you get luminal narrowing, the stenosis we measure.
And we talked about the paradox of low stress initiating plaque, but high stress potentially causing rupture later.
Exactly. While atheroma often deposits initially in those low shear stress zones, like the outer wall of the bifurcation, subsequent changes in geometry and flow mean that elevated shear stress, particularly acting on a thin fibrous cap, becomes a major factor in plaque rupture. The force literally exceeds the cap's strength.
So the location matters, and the type of stress matters at different stages.
Precisely. And studies looking at the mechanical forces within the plaque itself show that plaque wall stress and shear strain are often higher in vulnerable symptomatic plaques.
Are there anatomical factors too? Like, is everyone's bifurcation shaped the same?
No, there's variation. And things like a more acute, sharper angle where the internal carotid artery, ICA, branches off, where increased tortuosity, more bends and twists in the carotid artery are considered risk factors.
Why is that?
Because those features tend to create more disturbed flow patterns. A sharp angle can intensify the turbulence right at the origin of the ICA. A twisty artery exposes more of the wall to these unfavorable hemodynamic forces. So our individual anatomy can definitely play a role.
Fascinating. Our own plumbing design can influence risk. Okay, let's shift gears to biomarkers, clues in the blood. You mentioned imaging is primary now, but what's happening on the blood test front?
Right, imaging is definitely king for evaluation currently. Biomarkers are more in the research realm, though there's a lot of interest. Researchers are looking at various proteins, lipids, small molecules in the blood.
Trying to find something specific.
Yeah, ideally something that could indicate not just the presence of carotid disease, but specifically plaque vulnerability. Standard things like your cholesterol panel, LDL, HDL, and HbA1c for diabetes. They're linked to overall plaque development risk, sure.
But not specific to carotid or predicting symptoms.
Generally not specific enough, no. They don't reliably tell us if your carotid plaque is about to cause trouble or even how severe the stenosis is. They're more general cardiovascular risk markers.
So where's the research focused for unstable plaques? You mentioned inflammation earlier.
Absolutely. Since unstable plaques are characterized by inflammation, tissue breakdown, proteolysis, and cell death, apoptosis, researchers are keenly interested in serum markers that reflect these processes.
Like what specifically?
Matrix metalloproteinases, MMPs, are a big one. These are enzymes that break down the extracellular matrix, the scaffolding of tissues. Higher levels of certain MMPs, like MMP9, have been associated with plaque instability and rupture in some studies.
Okay, MMPs. What else?
Inflammatory cytokines, signaling molecules like interleukin-6, IL-6, TNF-alpha, maybe IL-18, and high-sensitivity C-reactive protein, hsCRP, a general inflammation marker. Some studies have shown correlations between these and vulnerable plaques or future events.
But I sense a but coming.
Well, the but is that many studies have been relatively small, and findings haven't always been consistently replicated. There's promise, but it's not yet clear-cut for clinical use.
What about adhesion molecules, things that make cells stick?
Yeah, molecules like selectins or VSAM1, which are involved in recruiting inflammatory cells to the plaque. There have been some promising associations reported, but also conflicting results. So, again, interesting, but controversial.
So the bottom line on blood tests for now.
The bottom line is that currently no single serum biomarker has been definitively proven in large prospective studies to reliably predict vulnerable carotid plaques or imminent stroke risk. MMPs probably show the most potential for maybe future adjunctive use alongside imaging, but we're not there yet.
Okay, so blood tests are still a work in progress. That really brings us back squarely to imaging, which you said is fundamental. And we're moving way beyond just measuring the narrowing now.
Absolutely. Imaging is where the major advances in understanding plaque vulnerability have happened clinically. We're using various techniques to actually see those high-risk features we've been talking about.
Let's start with ultrasound. It's so common. What are we looking at beyond flow speed?
Right. Traditional B-mode ultrasound gives us that grayscale anatomical image, and Doppler measures flow velocity to estimate stenosis. But now we pay much more attention to the plaque's echogenicity, basically, how bright or dark it appears.
The grayscale median, or GSM, you mentioned.
Exactly. We can quantify this. A high GSM, a brighter plaque, generally suggests more fibrous tissue or calcium, potentially more stable. A low GSM, meaning it's darker, more echolucent or hypoechoic, that's often indicative of that lipid-rich necrotic core.
So dark on ultrasound, potentially unstable.
That's the correlation, yes. Echolucency is strongly linked to those lipid-rich necrotic features and inflammation seen under the microscope. And importantly, a major meta-analysis showed that plaque echolucency predicts future cerebrovascular events, stroke, or TIA, in both asymptomatic and symptomatic patients, and that risk was independent of the degree of stenosis.
Wow, independent of stenosis. That's powerful.
It really highlights the importance of plaque composition. Researchers also look specifically for a juxtaluminal black area, a dark hypoechoic region right next to the blood flow channel. The thickness or presence of this area seems to linearly predict future stroke rates.
So the location of the darkness matters too.
It seems so. Also, just the overall plaque size or area measured on 2D ultrasound is itself a risk factor. Bigger plaques are generally riskier.
And combining features.
Yes. Studies looking at histology, the actual tissue, found that the combination of a large plaque area and a significant juxtaluminal black area on ultrasound was highly predictive of finding an unstable plaque under the microscope.
But you mentioned limitations earlier. Why isn't everyone getting this detailed ultrasound assessment?
Well, these advanced techniques, like accurately measuring GSM or identifying subtle features, can take more scanning time, require significant expertise and specific training for the sonographer, and we still need better standardization of the methods and equipment across different centers. So availability and consistency are challenges.
Makes sense. What about newer ultrasound tricks? Contrast-enhanced ultrasound, SMI.
Right, CEUS, contrast-enhanced ultrasound, uses microbubble contrast agents injected into the blood to improve visualization, particularly of blood flow within the plaque itself, that neovascularization we talked about.
Ah, seeing those leaky new vessels.
Exactly. And SMI, superb microvascular imaging, is a newer Doppler technique that's very sensitive for detecting slow flow in tiny vessels, potentially visualizing neovascularization without needing contrast.
How do they stack up?
Early studies are promising. One showed good agreement between CEUS and SMI in grading the amount of neovascularization. And importantly, the degree of neovascularization detected by both methods correlated well with plaque ecolucency, the darkness, suggesting they're all picking up features of vulnerability. But again, more validation is needed.
Still research phase, mostly.
Largely, yes. There's even experimental work using targeted microbubbles coated with antibodies to stick to inflammation markers on the vessel wall, which you could then visualize with ultrasound. Very futuristic stuff.
Very cool. What about 3D ultrasound? Does that add much?
3D ultrasound can provide more accurate measurements of plaque volume and, perhaps more importantly, the volume of any surface ulcerations. It can track changes over time better than 2D.
And does ulcer volume matter?
Yes, studies have shown that larger ulcer volumes measured by 3D ultrasound predict a higher risk of future stroke, TIA, and even death.
So why isn't 3D standard then?
Practical limitations currently. The transducers can be bulky, it requires specialized training, it's more expensive, and it's more sensitive to patient movement causing artifacts. So promising, but not routine yet. There's even 4D, which adds the time dimension.
Ultrasound keeps evolving. Briefly, what about IVUS, intravascular ultrasound, going inside the artery?
IVUS gives incredibly detailed images from inside the vessel, used a lot in coronary arteries. In carotids, the findings have been a bit less consistent regarding predicting vulnerability, and it's an invasive procedure, so it's not used for routine diagnosis. More of a research tool in this context.
Okay, so ultrasound offers a lot, especially with newer techniques. What about MRI? You said it correlates well with the actual tissue.
Yes, MRI is a very powerful tool here. Big advantages are no ionizing radiation and its excellent soft tissue contrast, which allows it to differentiate plaque components quite well.
What are the key features MRI picks up?
Multiple studies and meta-analyses have confirmed that MRI can reliably identify several key features of vulnerable plaques that predict future events. The big three are intraplaque hemorrhage, IPH, the lipid-rich necrotic core, LRNC, and a thin or ruptured fibrous cap, TRFC.
The same unstable features we discussed earlier.
Exactly. And the data linking these MRI findings to risk is pretty strong. One large meta-analysis found that detecting IPH LRNC, or TRFC, on MRI significantly predicted future stroke, or TIA, even after adjusting for stenosis and symptoms. IPH had the highest associated hazard ratio. It seemed to be the strongest predictor.
So seeing bleeding in the plaque on MRI is a major red flag.
It appears to be, yes. Several other large observational studies have backed this up, linking these specific MRI features to increased stroke risk in patients with carotid stenosis.
Are there other things MRI can show?
Yeah, researchers are developing novel MRI contrast agents that specifically target inflammation markers like macrophages within the plaque. There are also techniques like computational fluid dynamics based on MRI flow data, which can estimate wall shear stress. Some studies show higher plaque wall stress in ulcerated and symptomatic plaques using these methods.
Sounds very sophisticated, but are there barriers to using MRI for plaque characterization routinely?
Yes, definitely. Availability of MRI scanners and the specific hardware-software sequences needed for plaque imaging is one issue. It can sometimes be difficult to definitively distinguish recent IPH from luminal thrombus, the clot in the main channel. We still lack fully standardized imaging protocols and interpretation criteria across centers. And of course, some patients can't have MRIs due to pacemakers, claustrophobia, etc.
So like advanced ultrasound, powerful potential, but needs more standardization and validation.
Exactly. We need larger studies directly correlating these MRI findings with detailed histopathology of the plaques to really solidify its clinical role.
Okay, last imaging modality, CT scans. Widely used for arteries, right?
Yes, CT angiography, or CTA, is very common for assessing stenosis degree and looking at the overall anatomy of the neck arteries. It generally correlates well with ultrasound and catheter angiography for stenosis measurement.
Can it see plaque features too?
Standard CTA isn't great for plaque composition. However, high-resolution CTA techniques are emerging specifically for vulnerable plaque detection. One small study showed it had reasonable agreement with histology for identifying the lipid core in IPH. But it's still early days compared to MRI or advanced ultrasound for plaque characterization. Radiation exposure is also a consideration with CT.
Any other imaging approaches.
There's functional imaging, primarily PET scanning, positron emission tomography. Instead of anatomy, PT looks at metabolic activity or specific molecular targets.
How does that apply here?
Researchers use radioactive tracers, most commonly 18F-FDG, which is taken up by metabolically active cells like inflammatory cells, macrophages, in unstable plaques. Studies have shown higher FDG uptake in symptomatic carotid plaques compared to asymptomatic ones, and uptake correlates with inflammation markers in the tissue.
So PET could potentially flag inflamed active plaques.
That's the hope. Other tracers targeting specific molecules involved in inflammation or calcification are also being investigated. PET could offer a non-invasive way to assess the biological activity of a plaque, complementing the structural information from MRI or ultrasound. But again, largely a research tool for now.
It's incredible how much imaging has advanced beyond just seeing a blockage. But you mentioned earlier that clinical practice hasn't fully caught up.
That's right. Despite this wealth of knowledge about vulnerable plaque features, current clinical guidelines for deciding who needs intervention, like surgery, endarterectomy, or stenting, still heavily rely on just two main factors: the percentage of stenosis and whether the patient has had recent symptoms, like a stroke or TIA.
So even if imaging shows a really nasty-looking unstable plaque, if the stenosis is, say, 60% and the patient is asymptomatic,
under most current guidelines, they typically wouldn't be offered revascularization. The recommendations are generally for asymptomatic patients only if stenosis is severe, usually 70% or 80% or higher depending on the guideline, and for symptomatic patients if stenosis is typically 50% or greater.
but we know some people with less than 50% stenosis can have symptoms, right?
Exactly. There are definitely case series and studies reporting symptomatic patients with less than 50% stenosis who are found to have vulnerable plaque features like ulceration or IPH. These patients currently fall outside standard indications for intervention, but their plaque is clearly causing problems.
It highlights a potential gap.
It does. And adding to the complexity is the fact that plaques aren't static. They're dynamic structures. They can progress, they can regress, their composition can change over time due to ongoing biochemical stresses, biomechanical forces, medication effects.
So a plaque that looks stable today might not be stable next year.
Potentially, yes. Studies using serial imaging have shown significant changes in plaque size and composition, like the necrotic core or IPH, even over a period of just 1 year. This dynamic nature makes it really challenging to pinpoint the perfect time to intervene, especially in asymptomatic individuals.
So the reality is there are likely patients out there with moderate stenosis but really high-risk, unstable plaques who would benefit from treatment but aren't currently getting it based on stenosis alone.
That's the crux of the issue, and why this field is so active. Identifying these vulnerable carotid plaques, particularly in asymptomatic people, before they cause a stroke is a major goal. It requires integrating clinical factors, stenosis degree, and these advanced imaging features of plaque vulnerability. But we need more large prospective studies to really validate this approach and incorporate it into guidelines.
It really feels like the future of managing carotid disease is shifting then, moving towards a much more personalized risk assessment.
Absolutely. I think that's the key takeaway here. The focus is shifting decisively. It's less about just the degree of narrowing and much more about the inherent characteristics of the plaque itself, its stability or lack thereof. That seems to be the primary driver of stroke risk from carotid disease.
That's a fundamental change in thinking, and it really makes you wonder, doesn't it? Thinking ahead. What if, in the not-too-distant future, we have non-invasive imaging, maybe combined with biomarkers, that can reliably pinpoint these truly dangerous, unstable plaques, regardless of the stenosis percentage? Imagine if a relatively simple scan could reveal that ticking time bomb inside the artery wall, even if traditional tests show only mild or moderate blockage. That could completely revolutionize how we identify people at risk and who we decide to treat.
That's a very compelling thought.
Yeah.
It represents a potential paradigm shift towards truly preventative, personalized medicine in stroke care, a distinct possibility we're working towards.
Absolutely. For those of you listening who find this as fascinating as we do, I'd really encourage you to explore some of these areas further. Maybe look into the specifics of MRI plaque imaging, or advanced ultrasound techniques like CEUS or SMI, or delve into the research on inflammatory markers in vascular disease.
Yeah, it's a rapidly evolving field with a lot of exciting developments happening.
Definitely holds a lot of promise for the future.